Good afternoon. Welcome to the City of Joy. First of all, tell me about your experience about coming here to India.
Well,
Kolkata.
I keep coming back because I love it so much.
Okay.
It's great. I mean, I was here in Kolkata last year. You kindly invited me. It's a beautiful place. I've not been. India's a massive country.
Yeah.
I have had the opportunity to go to Kolkata to see Hyderabad, Lucknow, and it's just a wonderful country, wonderful people, and as you know, wonderful food. I like my food.
Next, coming to more serious things. So as you know, IgA nephropathy is very much prevalent in India as a part of the Southeast Asia. So it's a big menace here, and people want to know a lot about IgA nephropathy. So last time you had recommended that we should be we should check the urines more often for blood and protein. Any other advice that you would think of? I mean, as you were asked earlier in the day also, so when do you think that we should biopsy a patient? Should we biopsy them earlier on?
I think what the studies show us is that we need to make a diagnosis as early as possible.
Yeah.
So we need to be thinking about glomerular disease whenever we see an abnormal urine dipstick test, and that's not just nephrologists. That is anyone who dipsticks a patient's urine, primary care clinicians, general internal medicine doctors,
Yeah.
because an abnormal urine dipstick does not always mean a urinary tract infection. So I think we do need to train all of our colleagues to always think, is there a reason other than a UTI for a blood and protein in the urine? And it always needs following up.
Yeah.
Because certainly in my practice I see a lot of patients who present late but actually have identified blood and protein in their urine a lot sooner, but it's been discounted.
Yeah.
So I think we need to have a low threshold to think about a glomerular disease. We need to quantify the proteinuria or albuminuria, and we need as nephrologists to have a lower threshold to do a kidney biopsy. I think we need to be biopsying people, well, any person who has more than half a gram of proteinuria. And we probably even need to think about going lower, but let's wait and see. But I think we need to be making that diagnosis as soon as possible now that we have some potentially really exciting new treatments.
Yeah, so this reminds me of a patient, a female patient who's been reporting of, she's intelligent enough to notice that she's been having this microscopic hematuria in her urine tests. So, and they were not necessarily associated with UTI, and but she has trace proteinuria, but this has been going on for quite some time now. So, do you think we should go for a biopsy right now?
So I think if she's got, and in terms of quantifying that, I think we, depending on how much there is, I definitely think we should be thinking about making a diagnosis. How old is she? She's young?
About 35 to 40.
So as a mid-50-year-old, that's young.
30.
But she's young, isn't she? She wants those kidneys to work for the next 50 years.
Yeah.
So we need to know what's going on. There's a study that will come out in NDT in the near future that we wrote an editorial for, that's now looking at the increased risk of progression in patients with microalbuminuria and IgA nephropathy. So when you say trace of proteinuria, she may actually have microalbuminuria.
Yeah.
And in a diabetic, that's enough to trigger a lot of treatments, isn't it?
Yeah.
Whereas
So-
in this lady, she may have microalbuminuria and hematuria. We don't make a diagnosis. We need to know that so that we can treat her.
Yeah.
Because if she presents 15 years later with a GFR in the 50s, that's half her gloms have gone.
Yeah, so I had planned that, but now that I have your endorsement, I'll be more confident of doing it. And
Yeah, I think, and we're here at this meeting, and we can see lots of stalls, we can see therapies that are being looked at and marketed for IgA nephropathy.
Yeah.
We're having more drug approvals.
Yeah.
We have a whole range of the general CKD type treatments that are available.
Yeah.
And there are lots of clinical trials
Yeah.
going on in India, just like there are in Leicester in the UK.
Yeah.
So there are lots of opportunities for patients with IgA nephropathy to access new treatments.
Yeah. So there's a lot of awareness, even amongst the doctors, about regarding the new therapies that are being available now, thanks to these exposures that we're having in the form of different conferences, and also they're being discussed in the different journals. So we are hopefully looking to a better future for IgA nephropathy, except for the prohibitive costs of the medicines. Maybe.
That is a real challenge. I
Yeah.
mean, I think You know, we're having to, my lectures are being updated virtually every 6 months because we're having new treatments.
Yeah.
And that's really great. But there's no point having new treatments if the vast majority of the world can't afford
Cannot
them.
afford it, yeah.
And that's something we are going to bring up very strongly in the KDIGO update that we're writing at the moment. Because, you know, countries like India,
Especially complement inhibitors. I
yeah,
would say.
absolutely. But countries in East and Southeast Asia are working hard to deliver patients for clinical trials. Patients are going into clinical trials of experimental therapies, and then the
They
drugs are
cannot
getting
afford,
approved,
yeah.
and then they're never coming back to those
Yeah,
countries to
yeah.
be allowed to be used,
Yeah.
which is a crime, really. It's terrible. So there is a lot of work going on to try and encourage countries to allow accessibility, and some of the companies are being really really innovative in saying, if you come into my trial, I will guarantee that patient at the end of the study gets access to the drug until it is available in your country.
Okay.
And that transforms the landscape, and actually
Okay.
that's something we're really promoting, that patients should be going into those studies, because then they do get access, they get some form of payback for all the effort they gave going into a clinical trial.
Okay, so that's news. I didn't know about it. So that's good news. So I would end our discussions right here with good news for the patients particularly. And thanks a lot for traveling all the way here. And we hope that you come here again and again to enlighten us about the new developments.
Oh, if you ask, I will come, don't worry.
Okay.
Thank you.
Thank you, sir.